with the introduction. I'm going to go ahead and start with the introduction. And as people join in, just let them in. And if you can just track the chat box. Again, Dr. Javanbakht, I think it's still a teething problem. You're trying to figure out how to do the right venue for sharing this so that folks can join. But I would like to first start off with introducing Professor Javanbakht. It's my pleasure to introduce a wonderful friend and colleague and mentor, Professor Raj Javanbakht, a psychiatrist, neuroscientist, and founding director of Stress, Trauma, and Anxiety Research Clinic, the STAR Clinic. And it's grown wonderfully over the last, I would say, I think like a decade, around a decade ago, you started that. So nationally recognized for his work in anxiety, trauma, and PTSD, particular focus on refugees, first responder, trauma-affected population. Leads pioneering efforts in integrating AI, augmented reality, telemedicine, and holistic approaches to mindfulness and movement therapies into PTSD. I think his approach has been really unique, and he's secured grants for that effort that he's been doing. He's received numerous national, international honors for both scientific and humanitarian contribution. He's also the author of the book. If you guys haven't read it, you all should. Afraid. Understanding the purpose of fear and harnessing the power of anxiety. So it was a good buy for me. I did it. So today he will be speaking on war, trauma, refugee mental health, and creative ways to deal with it. Thank you, Dr. Javanbakht.
Thank you so much for the kind introduction. I appreciate you and I appreciate the great work you guys are doing. So I'll start with sharing my slides. Because it's a smaller group, feel free to stop me anytime if you have questions. I'm going to, yeah, so feel free to just, I may not see you, so raise your voice and tell me that you have a question, and we'll go from there. So these are my fundings. So as Dr. Kumar mentioned, I'm the director of STARK. And at the STARK, we look at everything that trauma does to the brain and the body. We look at epigenetics, inflammation, different markers of trauma and stress, and among refugees and trauma-exposed populations. And we are also involved in use of advanced technologies in helping patients with these conditions. So we have had a long study of looking at the impact of war trauma on civilians for about a decade. And before I get to the numbers and the statistics and this kind of data, I want to start with explaining what's the life of a refugee. Because a lot of times when we talk science and numbers and percentages, things turn to numbers rather than humans. And imagine wherever you are, one day you wake up with the sound of explosions and bombs dropping around you, and you don't know what's going on, who is in charge, who is against you, who is with you. If the group who's in charge of your neighborhood likes you or hates you, you don't have electricity, you don't have running water, and you don't know when this is going to end. And if you have kids, you don't know where to get the food, where to get the formula for the babies, how to keep them safe. And a lot of times, especially with refugees coming from the Middle East, you don't even have an army to protect you. You don't even have air defense systems. So you feel very, very exposed. And of course, as a civilian, you don't have training to how to protect yourself, how to save yourself. You don't even have a gun. So full sense of helplessness and hopelessness and lack of control over the environments. If you're lucky enough, after months or years after having lost family members and property and job and a lot of things in life, you may be lucky enough to leave the country and go to another country nearby and live in a refugee camp. Now, let's say you were a doctor, whoever you are, now you're nobody in this refugee camp with your family, trying to survive. You have left your culture, you have left your belongings, and these are very dense environments. Thousands of people, just one doctor, not much resources. And you have to survive day by day. And one day you may get again lucky and get a letter that, oh, you have been accepted as a refugee to go to this other country. You don't know that country, you don't know the culture, you don't know the people, you don't know the environment, you don't know the language, you don't know how credit cards works in that system. And let's say you were told you're going to America back in time. Now things have changed and you won't go to America. And your perception of America is the Hollywood movies and Home Alone, and you think, okay, I'm gonna go to a very beautiful, lovely place. They drop you to in a neighborhood with minimal resources. You don't have car, you don't have transportation. As I said, you don't know the language, you don't know how to interact with your neighbor, and you have to rebuild your life from scratch. I came here as a doctor. I was a physician trained in Iran. And when I came here, not as a refugee, I came as an immigrant. And when I came here, I became nobody. I'm not a doctor anymore. I had to go through a lot of exams and tests and everything. And I knew the language and the culture of the society to again become a doctor. So a lot happens to a refugee family over the course of years that is intense cumulative trauma and stress. When I joined Wayne State University, it was in the midst of the Syrian war. And I had a simple question. What's the impact of war exposure in these people? Looked at some data. There was some data about the prevalence of PTSD, depression, anxiety in these people. When we talk about PTSD, post-traumatic stress disorder, it's a condition that happens when people are exposed to horrible, atrocious experiences like war and assault and rape and robbery and torture. And basically, the brain goes to the fight and flight mode and never comes down from it. And it's stuck there. Everything could be dangerous. Everything is perceived as risk. The person is terrified. They cannot go out. They have nightmares. They have flashbacks. They avoid a lot of certain human experiences and interactions. And uh, feel depressed. A lot of depression also comes with PTSD. And you see here about a third of these populations in camps in those countries like Lebanon and Turkey had very high depression and PTSD level. There was no data in America. We didn't know, okay, all these people who come here, what's the impact of war on them? So we started this project, and less so was known about the impact of war trauma in children. And because children, there are not a lot of people who do children's studies, and the data has been minimal. So we started this project. We wanted to see what's the impact of war trauma in these people. Very simple question. And then we said, let's also add biological markers of trauma and stress and anxiety. And what does the trauma do to these people's bodies and brains? We were featured in a lot of media outlets, which is, I think, important if you do a scientific work to be able to tell the public what you're finding in a language understandable to the public. So the public see, okay, what is the life of a refugee? What are the challenges of these people? And also see a few faces of refugees, like CNN came and did a report on our work, and they went and talked to refugees and people, especially in that environment of the political environment of America. People were able to see, oh, this Syrian refugee is someone like me who has kids, and they're trying to survive, not people who came here to take everything we have from us. So how did we do it? We had to go to the community, and this was a work with the community directly. Um, uh, I got lucky and I met a group of doctors who were refugees from Iraq. And they wanted to do the same thing I did and do their residency exams and start training here. So they needed some research experience. We gathered, and then there was this primary care system in Dearborn, where basically was an Arab mental health system, Arab American Chaldean Council primary care clinics, where we basically went there. Our team would go there because refugees had to come there for their health screening, physical health screening, which was mandatory. And the doctor would say, hey, these guys are doing some research. Do you want to work with them? And then the refugees would come to us in the same clinic where our team were, and the team would collect data from them. Why is it important? Because as a refugee, as a trauma exposed person, the first thing you learn is that you cannot trust people. Especially if you came to America of that time, which was like a very highly political, you don't even know, are they gonna collect this data to deport me, or what's gonna happen? So the trust that that doctor in that clinic transferred to our team was very important, and our team members, being doctors, or people that others usually trust, being Middle Eastern, being Arabs, and also being refugees themselves, made it much easier for the refugees to trust them. And we needed to use very simple screeners, because if we had long questions of like 200 questions, we wouldn't be able to do this, because refugees were brought by drivers, and they had to do their thing quickly, and the drivers had to take them back. So we had very limited amount of time. So our team were collecting questions from the kids, from the parents, and also at the same time getting saliva for the genetic samples and all of that. This is our team. Zina is a doctor from Iraq, Farah, another doctor from Iraq, Zainab, Muhammad, same all of them. Hiba later came joined from Syria. And the rest are our researcher team. And then Hiba came from Jordan, Basim came from Egypt, Celine came from Syria, Raja came from Syria, and Dr. Rashid Al Ahmed, who is now a neurology resident in Toledo, came from Syria and took over. So gradually, a lot of people, and we had a lot of other kids join us from Wayne State, from other places, who were like, yeah, I'm a refugee, I'm a child of a refugee or migrant, and I want to work with this. So we basically built a very cool community where people came and did something that they found meaningful for their life. So when we started, well, in a short period of time before the travel ban last time stopped the flow of refugees to America, we were able to recruit more than 90% of people who were referred to us, which is very, very high number. And that speaks to the trust these people built for us. This is the breakdown of the Syrian adults and children and Iraqis. So these refugees both came from Iraq and Syria. And majority of these families were, I would say almost all of them, except for one, kids came with both of their parents. Everybody had all of their four limbs. We didn't have a lot of physical uh, uh, traumas, which means this was not the hardest hit population. It's important to say, because a lot of kids became orphans. A lot of people lost physical health, lost their limbs, and those somehow were not among this population. So I don't know how, but I say this to say this is probably not the hardest hit population, but still people who went through the war trauma and the refugee experience. This is the data on our adults, and you see it's like a half and half men and women. Majority were educated, majority were married. Almost half of them didn't speak English, and only 5% had a previous psychiatric diagnosis, which looks very low. Even in the US data, it's very low. Only 5% of people having mental health issues is very, very low. So it would be surprising if you just wanted to look and say, oh, this seems like a group who was not impacted much by war. But then we looked at our own data. The data we collected, about a third of our men and women both screened full criteria for PTSD. So these were people who screened positive for PTSD, which is much higher than 5%. And about half of our population had high anxiety and half had possible depression. So what does this mean? This means that over the course of those several years that they were in Syria and Iraq and in those camps, nobody even looked at their mental health. There was no resources. That I have talked to some of these people. There was, like in the Greece, there's this camp with thousands of refugees and just one primary care doctor. They don't even have the resources to see if there is impact. And we know all of these conditions, when they get chronic over time, they can really deteriorate person's mental health, physical health, and brain health. So this was very important. 1 in 3 full criteria for PTSD, not some level of symptoms. No, they passed the threshold for PTSD, because PTSD is not a disease which is 0 and 1. It's not like an infection that you either have it or you don't have it. You accumulate symptoms, nightmares, flashbacks, avoidances, this, that, over as at some level, let's say 70%, we draw a line and say, okay, from here on, we are going to call it PTSD. So take it with that aspect. And this number, which is a point prevalence, is comparable to the lifetime prevalence of PTSD among Vietnam War veterans, which were very, very hardly hit. Vietnam War was among the most traumatizing experiences. So the prevalence is very high. We also looked at comorbidities. In those who did have PTSD, very high percentage of them also screen positive for anxiety, depression, and both of them, which makes it even worse, because if I have PTSD and I also have depression and I also have high anxiety, I'm a lot more disabled. Now put this in the context that if I have PTSD and I have nightmares and flashbacks and feel depressed and I'm terrified of going out, how am I going to adjust to my new life here? Because as an immigrant, whoever is an immigrant here knows you have to navigate a lot of challenging, stressful, difficult situations. And if you already are highly stressed, this becomes very difficult. Then we looked at the children. We didn't have very high prevalence of PTSD, but we had very high level of anxiety, and more importantly, separation anxiety. About 80% of our kids have separation anxiety, which means they couldn't leave the side of their parents. And we see that, and we heard that from schools that we talked to, that they said these kids don't want to come to school. And it's not that they hate this school. The issue is that they are terrified of leaving their parents, because if you're a child who grow up in a very dangerous environment, the most reasonable thing is to stick to your parents and not want to leave their side, because the parents are the sole protectors of you. So if you go to school, you're separate from them. So a lot of somatic problems, stomach ache, backache, headache, that they didn't want to go to school because they were afraid. And the reason PTSD was low, we believe, is that probably either it's developmental and the kids develop more of a symptoms of raw anxiety rather than PTSD constellation per se. And also potentially their parents protected them against the impact of war trauma and kind of buffered the impact. We also looked at the country of origin. We had Syrians and we had Iraqis, and we looked at the prevalence, and prevalences were much higher among Syrians, and they were much higher among Arabs compared to Chaldeans. So who are Chaldeans? In Iraq, we have Muslims, Arabs, and we have Chaldeans, which is an ethnic Christian group. And why is this important? Because when we talk about refugees, not all refugees are the same and have the same experiences. We cannot apply the same rule to everybody. So here, Iraq, most of the Iraqis we had came from northern Iraq. It was later in the war. The country had stabilized a little bit. There was less of the war in the north. So, but Syria was in the midst of the explosions and bombings and civil war. So that explains why Syrians were more impacted than Iraqis. Now, about the Arabs and Chaldeans, we have also theories. Most of the Chaldeans, again, came from the northern parts of Iraq. And the other part is that we think that probably Muslims were much of a higher target for ISIS at that time, which was in Iraq, because they were seen as the most direct target and most direct rival and most direct competitors, enemies to be killed, unfortunately. And the other part is that they came to America, which is a majority Christian country, especially in a political time where Muslims were not very much welcome. So that there's also the perception of how much you're accepted in the country. And finally, Michigan has a lot of Chaldeans and has a good coherent Chaldean community. So probably the Chaldeans felt a little bit more welcome. If you haven't read Viktor Frankl, I recommend. Viktor Frankl was, during the World War II, he was a Jewish psychiatrist who was put in a concentration camp by Nazis. And he survived. And he turned this whole experience into a research study. He started learning about observing and seeing who survives better and who doesn't survive well. He looked at resilience in himself and others. And actually the meaning he created for his own experience was something that helped him survive those atrocities himself. He came up with the idea that when you have a meaning, when you have a purpose, when you create a different meaning for the experience, you survive better. And why am I bringing this up? Because we also looked at kind of a little bit with simple questions at this aspect. how does the meaning of my experiences affect the way I am hit? So we just put one simple question. How would you rate your whole general health today? From poor to excellent. You didn't ask what disease you have, if you have a disease, if you're taking pills. No. What do you feel about your physical health? And they gave us a score. Then we also asked them, I put just one simple question. On a scale from 1 to 7, 7 being the worst thing ever happened to you, how bad was this whole thing? Didn't ask like 50 questions of this part of the experience, that was our experience, all of that. And what we found was that though majority of people said their health is good, and about half of them said this is the worst thing that has ever happened to me, perceived health and adversity correlated with depression in those with depression and anxiety. If you had depression and anxiety, perceived health and adversity related to. So the worse I saw what is out there, and the worse connected to the worse I saw the things inside my head and inside my own body. And among those who had the worst perception of their experience and the worst perception of their own health, about 82% compared to 30% of the whole group were PTSD plus, PTSD positive, which basically gives an idea that how things are in my head, how things are in my body, and how I perceive that the world out there are very much interconnected. It's one system, one cognitive emotional system processing all of the data. Now, somebody could say, well, these people came to America, now America is safe and they don't hear the explosions and there's no war, they should be okay now, right? We said, let's test that. We went to them and looked at it 2 years later and see how they're faring 2 years later. We went to their homes and we collected the exact same data from all these families now. Of course, we had attrition and some people left. What we found was that symptoms very often do not improve by time. So the average PTSD scores didn't change over time among these adults. And for some of them, some of them actually it got worse. Those who were tortured, those who were assaulted, those who had personal experiences of trauma and threat to life, their symptoms even got worse over time, which means if the trauma, and we know that from research that if the trauma source is intimate, by intimate mean a human perpetrating the trauma on me, whether it's rape or assault or abuse or torture or threats like that, the impact is higher, and over time it seems like it may even get worse. Again, we looked at the children data and the anxiety didn't change on average among children. Of course, some people get better, some people get worse. On average, symptoms didn't change. Same applied to the PTSD scores among children. We also looked at how maternal symptoms may or may not relate to that of their children. Because we see, well, we usually in Western medicine see person as one, but this family is a group, is a whole. They come together, they have shared experiences. And kids specifically learn from their parents how to be stressed. And when we looked at that, we found that our kids had, the more stressed the parents were, the mothers were, the more stressed the kids were when they came to America, which is understandable, which speaks to shared experiences also. If my mom is terrified, it means the world is dangerous out there, and I would be terrified. So mom's PTSD symptoms and kids' anxiety is correlated. We also found that the more exposure to death trauma mother had, depression got worse in children. And this is 2 years later. So one thing we learned also is that it continued. And mom's trauma exposure at the time one also predicted kids' symptoms over the course of 2 years later. So the healthier, the more comfortable, the more safe mother feels, you can predict that over the course of 2 years, the kids will fare better also. Same we found with fathers then. So now we see that father symptoms also. What's interesting is that when they just came, we didn't find correlation between father's symptoms and those of their children. But 2 years later, we found a correlation. And I believe this is because Maybe in the beginning, fathers had a role of more of being out there, watching out for the threat and basically being the gatekeeper while mom is with the kids. So mom's symptoms affect more of the kids, and maybe father had to conceal their own symptoms and not show it because they have to be the gatekeeper. Now they come to a fine, safe environment, and father can become a father again and be part of the family and be more engaged with the family. And now their symptoms correlate with those of the kids. We also found the symptoms of couples very much correlated with each other. So it's just one system. And that's important because if you want to address trauma, stress, anxiety in families who have had shared experiences, maybe you got to address it among the whole family together. We also measured post-migration difficulties, which means we asked them when they came, how do they feel in terms of safety and support for each of these aspects of their life? Housing, health services, finances, social support, government support, all of that. How do they feel? And what we found was that the lower the parent's environmental stress, the better was the improvement in children's symptoms 2 years later. We also look at the epigenetic age acceleration, basically so our gene, there's a telomere in our at the end of our DNA, and this telomere, the longer it is, the better it is. The healthier we are because it basically protects the DNA from damage. And we know stress and trauma lead to reduction in the size of the telomere. And what we found was that during the wave one, when they just came to America, their epigenetic age very much associated with their anxiety symptoms. So the anxiety symptoms, the more higher anxiety, the smaller the telomere. Basically, the war trauma exposure damage the telomere. And there are other people in our institution. Actually, maybe Dr. Kumar, you want to invite her to present. Dr. Dalia Khalil. She is at School of Nursing, and she is looking at mothers who came here or women who came here and now they have children here. And she found the more stressed the mothers, the lower the basically telomere length in the babies who were born here in America. So it can be transferred from mothers to their kids. Then when the war in unfortunately these days we are not lacking wars in this world, so the war in Ukraine started, and we wanted to look and see what's going on, and we knew that there's high prevalence of PTSD among Ukrainians also who are war exposed. Now Ukraine is a different environment, and you cannot look at Ukraine as one place, because when the war started, a lot of people moved to the west side of Ukraine, and the west and the middle of Ukraine is less unsafe compared to the east side, which is next to Russia and on the border, and there's a lot of war going on, a lot of uncertainties. Of course, there's constant drone and missile attacks in Kiev and other parts of Ukraine, so the life of these people for the past several years has been this. But I got reached out by this guy, Austin, who was a student, undergrad student in Boston, Sadler's College, and he decided that he wants to, when the war started, he wants to go to Ukraine, to the front line, and join a mobile health clinic. And these clinics would just go to the deoccupied villages on the eastern side of Ukraine and look at and basically deliver medical needs and medications to people who were left there. And you shouldn't see Ukraine as Europe. Ukraine is not as wealthy and as rich as the rest of the Western Europe. So there are a lot of villages on the east side of Ukraine with very minimal resources, especially during the war. Things were terrible. So we said, let's look at the impact of trauma in these people. And this was a unique population because these are people who are in the war. They didn't leave it, because most of the studies of war exposed people, like our other studies with Syrian refugees, they left the war. Now we are looking at it now, but these people are actively in the front line. They hear the rockets, they see the explosions, and they are at the constant threat of, okay, the border is going to move towards us, and at some point Russia may occupy our land. So these are areas which were occupied by Russians, then the Ukrainians pushed them back, and this young man was able to collect data on more than 450 adults during this time, which is amazing. And we found more than half of these people screen positive for PTSD, which is very, very high. And we didn't see any sex difference the same way we did with our Syrian and Iraqi refugees. Why is it important? Because traditionally women are more affected by men with by trauma, but here we didn't see that pattern. And I believe it's because probably the trauma is so severe that whoever has any vulnerability, they will show the symptoms now. It's just beyond regular, normal one episode experience of trauma. And on top of that, there's high level of adversity and ongoing stress with it. Okay. Then Austin, we looked at what are the variables that could affect the what are the variables that could affect my PTSD symptoms, and what we found was the most important variable and most significant was loneliness. The more lonely these people felt, the worse was their experience of PTSD symptoms. So that is very important because we look at a lot of things, interventions, treatments, this, that, which are costly, but at the end of the day, feeling lonely, being disconnected, being detached is a very important variable in predicting severity of symptoms. And that's even more important among people like refugees, because these people came to society. A lot of them may not. Like if you're a Syrian refugee, you come to Michigan, it's not too difficult to find a community to connect with, because there are a lot of Middle Eastern, especially Lebanese, Syrian, Iraqi people living in the state of Michigan. But let's say if you go to another state, or if you go to another country where there aren't a lot of Arabs there, it would be harder to find a community and the symptoms may get worse. So we were doing our research, but I knew that I'm not doing anything for these people. And it wasn't great, because we are like, okay, we are showing that the prevalence is so high, but we are not helping them. And that's why we thought about doing some interventions. And traditionally, we knew it's very hard to basically implement treatments which are culturally and language-wise understood and relatable. And we didn't have a lot of therapists who were trauma-informed and knew Arabic and the culture. So we didn't know what to do until this young lady, Lana Grasser, who's now a professor at Wayne State University, joined my lab as a PhD student in neuroscience, turned out to be a dancer. And she said, I want to do dance therapy for these kids. And then Dr. Holly Finn Callaghan, below here, came to me and said, we want to do we do art therapy. How about we do art therapy for these kids? And we found these methods doable because they are not expensive, they are easy to use and implement, and they can be done in a group setup. And the kids and the families don't have to talk about their trauma. They express their emotions indirectly through a different language. And we said, okay, let's do it, and also let's research it. And we put together a team of volunteers, and I basically this community organization that was basically Samaritas supporting refugees. They had their volunteer drivers that would go pick a mom and a kid and bring them to our clinic, and kids would do art and dance and movement therapies, and mothers would do mindful yoga. I brought my own yoga teacher from Ann Arbor also, and we measured this. What we found was that we had very good retention. 73% of these people remain in the treatment, and we had good change of symptoms over time in depression, PTSD, and anxiety symptoms among the kids. And we had the same impact among the in anxiety and PTSD symptoms during within art therapy. Later on, we expanded these interventions into other refugee groups. We did that through the schools, during the COVID time, through the school video teaching, education platforms, and then other groups of refugees and urban trauma exposed populations, and implemented some of this in Ukraine. But then the state of Michigan came to us and said, hey, we want to learn how to work with these refugee children because we are having challenges. Because a lot of our teachers find it difficult to understand the specific needs of these kids. They get angry, they get terrified, they get scared. The alarm goes off in the school. There's a fire drill and they panic. What should we do? So we put together this team, and we basically, over a course of 2 years, consulted with schools. We trained some trainers to go to schools and help the teachers have a better understanding of trauma-informed, basically, education for these kids. Now, I mentioned that we are having some cool technologies. We use augmented reality for basically interacting with digital environments. And for a lot of refugees, it's hard to be among the host communities. We talked about PTSD and how avoidance is part of PTSD. And also the challenge that most Arab refugees who come to Michigan, they only would go to Arabic store. I mean, a lot of immigrants are like that, right? It's hard to basically integrate to the whole society. So they have Arab friends, they have Arab Facebook, they have their boss is Arabic, their store, grocery store, restaurant, everything. Which is good to have a community, but at the same time, you don't want to live in an island in a huge country that is going to be your home country for the rest of your life. So we wanted to help these people integrate in those in the new environments. And again, Dr. Dalia Khalil, and I'm sorry, so we have this technology, I forgot this one. You wear these goggles, which are augmented reality, not virtual reality. Imagine you have the glasses you're wearing, and your glasses show you the real and unreal combined. So this woman here with the laptop is Mackenzie. She's a real human, but these other digital humans are not real. And Mackenzie can help you walk around this restaurant or grocery store and interact with these American people. And Dalia Khalil is using this to help. We created this for treating PTSD, anxiety, agoraphobia, those kind of conditions. But Dalia is using this to help her refugee mothers feel more comfortable in interacting with these environments. They don't have PTSD, they're not being treated, they're just learning how to, or having conversation, AI motivated conversation with a digital human with their broken English, because a lot of them feel uncomfortable having these conversations because they're worried they may be judged because their English is not that good. And that's going very well. The anxieties in these people are going down and they're really liking it. Actually, I talked a lot about this technology. Let me show you a video of it. This is how it works. So when you wear the goggles, there's a 3D map around you of the environment, and the operator will basically draw these lines around the patient, around the person, around the user, and this is what you see through your headset. They take you to a grocery store.
How much pasta do you think we should buy? I think 12 people are coming over.
It's actually 10. Bill and Sarah canceled. I think we need 4 boxes of pasta and 3 jars of sauce.
Beltline was a mess. So we
need to start buying from a different shop.
Industry.
I can see if that does the trick.
We can incorporate the
I want my granddaughter to build her confidence in fish. I'm going to write it in the annual.
So you can have it in different environments. Now we're going to party here. Or you can even have this, let's say I want to talk to a group of people. You put these people in front of me.
This technology has been very helpful
Detroit,
in creating real-world environments that our patients avoid because of their trauma and anxiety. Any questions?
What do you envision for the future of this technology?
So they can talk to you and you talk back to them. So I've written, if you're interested, a few of these other articles about what is the impact that we expect when each of these wars started? I started writing about what to predict from coming to these people and what are the ways we might be able to help these people within those very low resource environments and situations. And we have a few minutes, right? We have like 5 minutes.
We have 15 minutes.
15 minutes.
Yeah.
Okay. But we also want some time for questions.
Yeah.
Yeah. So I can talk a little bit about barriers. Are there any clinicians here?
Yeah, I think quite a few of them are, I know Charles, Henry.
Okay, then I can talk about, okay, there are barriers to talk, basically working with these populations and serving them. Some of them are related to logistical issues and lack of access, and some of them are because of the lack of trust and issues. Stigma is a big thing. Stigma is a big issue. Cultural barriers are big. There are biases on both sides. There's a bias on the side of the patient, person, refugee, that biases towards, okay, what does an authority mean? What does a healthcare provider mean? What does a healthcare system mean? And then there are biases on the side of the provider, and these biases are not necessarily evil things. It's just like a perception the person has. Oh, a person coming from the Middle East might have these assumptions. Oh, a person coming from Ukraine or this or that other person place may have assumption. But it is actually Dahlia again had a very beautiful talk about perceptions of pregnant mothers coming from different cultures. And the same way these perceptions are so diverse across America, same applies to other countries. Someone coming from a very small village in Syria and someone coming from Damascus, they have very, very different perceptions, different. So you cannot basically generalize everything to everybody. So it's important to have some ideas, but not trust them so much. A lot of times symptoms in these people present themselves in a form of somatization because of this stigma. You're not allowed to be depressed. You're not allowed to be anxious. But it's okay to have back pain. It's okay to have headache. I used to, when I was in Iran, I'm Iranian. When I was in Iran 20 some years ago, as a physician, I used to go work in this village, basically as my social services for free medical training. And a lot of people would come with burning sensation on the top of their head, with headache. And I would ask indirectly some other questions. It was clear they're depressed. I would give them antidepressants and they would come back and the headache was gone. Because it was depression only allowing itself to present itself in that language. Families may interfere. I've had even like a kids whose mothers or fathers were like, no, my kid is not crazy. They don't need mental health care, this, that, you know. And some blame is on us. We don't want to go tell mother that, oh, your child has PTSD and PTSD is a terrible condition, is going to remain with them. You got to use the language that is understandable to those people. And sometimes they don't know what is okay and what is not okay. Like I also work with first responders, which is a similar population, civilians exposed to a lot of trauma. I have cops who tell me that I thought having flashbacks and nightmares every day is part of career of being a cop. They don't know what is abnormal and can be treated. Parental resistance. Sometimes parents don't want to address these in their kids because if they accept, to them it may mean the child is damaged, their child is weak, their child is worse than others, or they are not a good parent. Or if I'm a good mother, my child should not feel depressed or anxious. They don't want to accept their child is crazy. They feel like, oh, if you diagnose my child with the disease, it means you're going to put them in a hospital or force them to take medications, right? You know, there are a lot of stigmas, not just in other countries, also in America, that people think they still have that old-time perception that psychiatrist is going to force horrible medications on them. Sometimes religious beliefs are like, oh, go pray, and if you believe in God, you shouldn't be depressed, right? And sometimes, unfortunately, the culture, the environment can enforce that. So there's shame as a result in that. And I can do it myself, I should be able to do it myself, because they, especially for people who have been trauma exposed, that sense of control is very important. They want, because control is taken away from them. It's hard to give it to others. You want to keep it to yourself. They don't want to share control. And trust is also very hard. People who have been traumatized, it's very hard for them to trust others. That's why I give them time and I gradually and give them options. I say, well, you don't want the medication, let's go talk to your religious leader, go talk to your therapist for a couple of months, and then come back in a couple of months and see how, if things are better or worse, and then we can consider our treatment. I give them a control. I'm your consultant. I'm not forcing you. I give you options here. I think this medication can help you. And I tell them, before even they ask me, I tell them, okay, this medication is not addictive. It's not going to change who you are. It's not going to zombify you. If you had side effects, we will change it. And then I give them choices. So rather than saying, this is the medication, go do it, I say, I have this medication that helps you with your anxiety and your sleep, and I have this medication that helps you with your anxiety and your pain. Which one would you prefer? Now they have choice. Now they can choose what works best for them. Working with parents, I remember this Iraqi young man, college student, came to me and he had severe depression. And we talked and I realized he needs medication. I prescribed a medication for him. Came back next month and said, my mom says you shouldn't take this medication. You should just go walk and your depression should go away. So now I could start a fight with mom or tell him your mom is stupid and she doesn't understand all of that. But I knew the mom really cares about her son. Within her mindset, that's the right thing. So I picked up the phone and called mom. And we chatted with mom about this whole thing. So next time the kid came, he said, my mom every day reminds me to take my pills. Now, mom became an ally in this work rather than being a competitor or being a foe or enemy. And this is the book that Dr. Kumar mentioned, actually is now translated to Arabic and Korean, and the Ukrainian and Farsi version are coming soon also. It's a kind of an encyclopedia of fear, anxiety, trauma from evolution to politics. So that was my talk. And if there are questions, I'll be happy to answer.
Wonderful, Dr. Javanbakht. I think this is, yeah, your lecture is always so inspiring to the works that can be done and opportunities that are there. So I'm gonna open it up to the folks. I think we got quite a few folks here. So anyone with any kind questions for Dr. Javanbakht, please go ahead, raise your hand, or just go ahead and unmute and ask your question. Don't feel shy. Yeah, go ahead, Hakeem.
Hello, yes, Dr. Kumar. Thank you for this wonderful lecture, and Dr. Javanbakht, thank you so much. We see some patients in trauma and emergency department. Actually, they come with like MVCs, and sometimes there is a co-passenger death, and I mean, they are very anxious and they don't cooperate sometimes in the emergency department evaluation. And we feel like if this situation can be controlled in the future, I mean, the amount of mental trauma they went through is going to be like kind of less. How is it like ATLS tells something about a little bit about like trauma management and the mental effects on trauma. Can you give us more light on this one?
Sure. And Hakeem, two questions. Where are you from? That's number one. Number two is that what kind of trauma? Are these like car accident traumas?
The majority are car accident traumas, but we see like even sometimes gunshots and sometimes assaults and other stuff. I'm from Texas. Yeah, I'm a PGY3 emergency resident.
Okay, okay. So in the immediate aftermath of trauma, what you want to offer the person is support and a feeling of trust. So as I said, control is taken from them, they are terrified. They're in a heightened state of lack of control. So you want to give them control. You want to give them time, be a little bit slower with them, and give them support. The first thing, do you want to eat something? Do you want something to drink? Are you feeling warm? Are you feeling comfortable? Do you want to sit here? Or where is your pain? Rather than getting more intensive with the other questions. Of course, there are questions that you have to ask, but explain the process, explain the procedures, explain all the aspects that need to. So every procedure to be explained even in more details for them in an understandable language for them. Now, if they're extremely intense and terrified, a small dose of benzodiazepine at the moment would be helpful to reduce that intense level of anxiety. Over time, for some people, these go away. Not everybody who's trauma exposed develops PTSD. So a certain percent of people, because of whatever neurobiological differences and trauma intensity, develop PTSD. So over the course of weeks, a lot of them lose their symptoms and the symptoms decline.
Yes, thank you. Thank you so much, Doc. Yeah, thank you for your work for the refugees and for the war-torn people.
My pleasure. I appreciate you. Thank you so much.
Welcome.
Thanks, Hakeem. So I see, sorry, I thought Henry had his hand up. Anybody else have the hand up, have a question? I think we're getting close to the time. I see Deanne is here. I see Deanne Soros out here. I see Henry is joining back. So Deanne works with a lot with resilience. And I had a question that could piggyback on the work that Deanne is doing. Is there I know resilience and post-trauma goes together. I think how do you cope with post-trauma? That's like the resilience of an individual to cope with trauma. And I think is there an opportunity to use AI to improve resilience among patients who have just these are patients who have not not been fall into the category of PTSD, but is there an opportunity to use AI, augmented reality, to help develop individual resilience for in trauma or disaster?
That's a very, very good question. I may think of, so we are not talking about treatment, we are talking about maybe helping them feel more comfortable, let's say in a busy emergency room, putting these goggles on them and them have a normal supportive conversation with a peer that looks like them, sounds like them, maybe from their own race and culture, and then have those like a psychoeducation, the least, and having not being alone in the corner of the emergency room, having that kind of conversation. I haven't done research on this, but that's a possibility I can see, because we have a library of more than 100 characters of different age, sex, race, body type, all of that, and you can put them in front of the patient and have them have those calming conversations with a kind of a peer being there who's supporting them.
Wonderful, yeah. I see Henry has come back. Henry, I thought I saw your hand up there. Go ahead.
Yeah, thank you, Dr. Kumal and Narash for the presentation. Mine is around, I picked interest in the arts-based therapy, especially looking at the young people. Is there a specific period in which they are exposed to this kind of intervention? And would there be any variations or in the terms of the outcomes depending on the exposure? Are there apart from yoga, are there any other approach that are being employed that would also be scaled up, and what would it take? I saw it's a cost-effective intervention. What would it require to be scaled up? Thank you.
Yeah, so I wouldn't say there's a certain timing. What I say is the sooner the better, because the more it goes after the symptoms develop, the worse it gets. Because the more anxious I get, the more I avoid, and the more I avoid, the more anxious I will get, and things get worse over time. So the sooner we can do it, the better. We use it like for Afghani refugees. We did it right in the hotels when they just came to America. Our team went to the hotels and delivered these interventions for them right there. And besides the yoga, so we used yoga for the mothers, for the kids. We did art therapy and dance and movement therapies, basically uh, presenting the bodily experiences through emotion and through dance practices, also art, basically creative art, painting, drawing, putting things and writing them and putting them in the jar. And those kind of experiences, they were able to express the emotions, and the emotions were delivered. There was also this photography project where each of them were given a camera and they were taking photos, and they brought that, and then they were discussing those photos and what they mean to them, drawing the flag of their country, and basically building a sense. It's also a sense of community building among them, because we talked about loneliness, and now these people are together and they are building a community within within these group settings and making friends. So a lot of these moms afterwards stayed in touch with each other.
Wonderful. I think answers part of the question that Henry. I think Henry is coming because I think we are looking to apply for a grant where we want to come up with some sort of like mechanism to help young traumatized children in Uganda. And I think whether this could be something that could be implemented in that regard.
I would say very much so, because these are easy to train. You can easily train someone to do art therapy and dance therapy, or it can even be done remotely. And we have people, I can connect you guys with Holly and Lana and the people who basically do these interventions within Wayne State University. And it's doable. It's much easier than training someone doing psychotherapy.
Wonderful. Thank you. And I see Deanne has her hands up. Go ahead, Deanne.
Mute. Video.
Yep.
Hi, good morning. Right,
Good
so
morning.
are you all hearing me?
Yep.
Yes.
Okay. So I missed the first part. I realized the timing, so I had it for 10 o'clock. Anyway, I managed to figure out, oh no, it's not 10, it's 9 o'clock my time. Anyhow, here I am. So we have, children in the inner cities here. I think they're exposed to more physical violence, but what has happened in recent time, you must have heard about Hurricane Melissa. And there were some serious issues in the western end of the island, and the psychiatrists have been actually using some of what you're speaking about, coloring therapy and whatnot, because the PTSD is starting to reveal itself now.
Mm-hmm.
And I suppose some of them would have similar issues to refugees because a lot of them lost their homes and they've had to be relocated. So is there anything that you could suggest or would suggest different that might augment some of their recovery process? And of course, they still have all of the issues they speak about, the hesitance to quote unquote admit that something might be wrong, and it's the same thing.
I can think of two things. One is that if you want, I can connect you. If you email me, I can connect you with Dr. Holly Finn-Callaghan, who leads the art therapy. So she might be able to talk to the team there and share her experiences and even train them in some aspects. The other thing that it comes to psychotherapies, I mean, if only a couple of therapists there are trained in doing the psychotherapies, that will be very helpful. And then for the medications a lot of times do a lot. And I know there is stigma, there is challenges in accepting them, but there are ways around stigma, because we're not giving scary medications. These are just anxiety and depression medications, very simple SSRIs. And a primary care doctor even can be trained in doing that, because it's not necessarily needing a psychiatrist, because a lot of times there aren't enough psychiatrists to serve. And a lot of times patients don't even want to go to a psychiatrist because they say, I'm not crazy. Why should I see a psychiatrist?
Absolutely.
And we can train primary care doctors. Actually, in that those papers in Ukraine and Gaza that I shared that written, I've suggested that it's easy to train a primary care doctor using these medications in a better, easier, more understandable language. Oh, you are feeling very scared and you have headache. Let's give you some medication to calm your system down a little bit.
Yeah, so he said that we're kind of in the honeymoon period and he expects to see more things reveal themselves with time, as people have their homes fixed and so on. So it's gonna be a long road.
I agree more may come, because a lot of people are trying to solve it by themselves, and then at some point they figure out no, they couldn't do it, and then more of it will come out.
I'll get in touch with the team leader and hear what he has to say, see what they have an update on.
Yeah.
Thank you.
My pleasure. Nice to meet you.
Thank you. Thank you. I think we've gone a few minutes over 11. Arash, as usual, wonderful presentation. What I'm going to do is a lot of the folks, we always seem to have an issue with the time. So we're going to share the recording that we have with everybody, so that everybody gets access to the wonderful talk. And also we'll share your email, Arash, with everyone, if it's okay with you.